Thank you for joining today. I'm Adve, and I'm the creator of a platform called Moral Sphere, which is like where I just encourage debate and complex ethical topics amongst young people. And the website is called moralsphere.org. So first, can you tell our users about your background and like what do you do and what kind of doctor are you?
I'm a kidney specialist. That's my background.
Okay, so do you have a lot of experience on this topic, like any relevance for like assisted dying and euthanasia?
Now that's primarily no euthanasia. No, we don't have that in Singapore. But what we do have is care for terminally ill. So there are some patients who don't have a condition that can be cured, and when that condition becomes quite advanced, for whatever reason, if they either choose not to get treated or definitive treatment for it, and they have the right to decline care that would otherwise prolong life. So for these patients, we offer palliative medicine, and there are specialists who are specifically trained and qualified in this field. So we get such specialists on board, and they look after the patient during their final days or weeks. Yeah.
So can you
Their role would be to manage symptoms, minimize suffering, preserve dignity of life, and care for them in a manner that's consistent with the patient's wishes.
can you explain the difference between assisted dying and euthanasia?
Yeah, it's if the patient gets the doctor to inject the medications, the cocktail, uh, that would lead to their eventual demise. So if the patient does it himself, it's physician assisted dying. So the physician prescribes the medicine and arranges for it, and the patient presses the button or pushes the injection. If the physician were to do it, then that's euthanasia.
So when doctors talk about someone having a good quality of life, what kind of things are they thinking about?
Well, it's not us thinking. Um, excuse me. Yeah, so it's not us thinking about it, it's patient's perception. Yeah. Now, I might, looking at the patient, he's in a or she is in a air-conditioned room attended by servants. I may think that the life is good and they have a TV to watch and whatnot. But the patient may perceive it as not compatible with the standards that they have for themselves. They might be in incessant pain. They may have refractory vomiting. They may have breathing difficulty. So that's not my judgment to make, but that's for the patient to determine. Yeah, whether their life is of quality that's worthwhile pursuing, or would they not prefer to do so? Yeah.
So can you expand more about the different ways a doctor and the team can make the person more comfortable even if they can't be cured?
Yeah. So there are various ways. One is you treat the symptoms. So if the patient is in pain, we administer pain medicine. If the patient has difficulty breathing, we administer oxygen. Sometimes there might be a medicine such as fentanyl that can diminish or blunt the air hunger someone has when their oxygen levels are low. Some brain-related conditions may be associated with seizures, as for example, and so administering medicines to break the seizures, and sometimes we are just palliating from the effects of the pain medicines themselves. So pain medicines lead to constipation sometimes. So administering medicines to give them relief. So and there might be other dimensions. We might get a psychologist involved when the family needs support. We might get social workers involved, as the case may be, getting a lawyer involved to help with, planning the estate and whatnot. So it's a multi-dimensional, uh, effort. It's a multi-member team effort. Yeah.
So what is the definition, like the direct definition of palliative care?
Um, Comfort in rendering measures, medical measures or nursing measures that render comfort to the patient. If it is, frequent positioning, if you're in the same position, that may lead to bed sores, which might lead to pain and infection. So that might be just a palliative measure, or administering medicine for fever. If somebody has a terminal infection, sometimes turning the fan on when you have air hunger, or it might be medication administration, such as for pain, such as for nausea, such as for vomiting, seizures, constipation. If their complaint is intractable hiccups, there are medications for that. So, yeah.
So if a patient who is in great pain requested to end their life, how do you balance that with the promise to help them? And do
Yeah.
doctors have like that inner debate?
Yeah, so in Singapore, we don't have physician-assisted suicide. In fact, there are very few countries that allow that. Certain states in the United States, most states in Australia, except I believe Northern Territory, and then European countries, Switzerland, some South American countries, I believe Ecuador is one of them. These are the countries where physician-assisted dying or euthanasia is permissible under law. However, in Singapore, what we have is care for terminal conditions that basically, so let's say a patient has a terminal cancer. We'll use the example of, advanced stage pancreatic cancer, as for example. Um, Surgery has been tried, um, chemotherapy has been tried, and there are new experimental things that the patient says that, doc, I've had enough. I've been through this. I've put my family through this. I put myself through this. I just want to go peacefully. And that's when we can't pull the plug. I mean, we don't actually have the ability to administer medications that would hasten their demise. That is not allowed in Singapore under the current legal provisions. However, we are allowed relief. So short of a curative thing, there are just so many things that we can do to bring relief to the patient, either partial or complete relief. So that's what we do. So physician assisted suicide is not permissible under law in majority of the countries in the world, and Singapore uh, does not have that provision also. Yeah. So
So
let's say somebody gives now patient autonomy becomes the paramount thing. The physician paternalistic behavior takes a backseat. If the patient has an advanced medical directive, or what we call as a proxy or a power of attorney when it comes to health related matters, we go with that person. We try to look after the patient in a manner that's consistent with the patient's either written wishes or explicitly stated, as stated to their power of attorney, or their legal representative. And we deliver care in the best interest of patients in a manner that's consistent with their belief system and framework. Yeah,
so like the patient has more has the ability to make the choices.
that's right. Yeah, assuming the patient. So if the patient has a condition which makes it hard for them to communicate. Let's say they've lost their ability to think. Let's say that there's someone with a terminal dementia. Uh, then we look at what have um, they conveyed through their advanced medical directive, which is also a legally valid document that we can refer to. So during their better days, where they have the faculties intact, what was their thing? So some people would say, don't put me on life support if my condition is terminal, right? Do not prolong life through heroic measures. So if my heart were to stop, so there are different uh, levels. So there is a DNR document, or do not resuscitate. Yeah. Uh, this is a document that's valid for someone who's hospitalized, as for example. And let's say that the patient has been on life support and repeatedly having cardiac arrest with very limited scope of recovery or meaningful recovery. So, in this kind of a situation, um, one of the principles of medical ethics is that the doctors are not morally or legally obligated to offer a line of treatment that is deemed to be medically futile. So just because you can do something doesn't mean that you must. For example, if someone has a cardiac arrest and I know that the heart is in such a bad condition that resuscitation would just result in rib fractures and adding to the patient distress without meaningfully prolonging the survival, then that by itself becomes medically futile to undertake. So in this situation, doctors can take the call to say that, you know, resuscitation is going to be a futile exercise, and in the best interest of patient, it may be just better to withhold resuscitation. Sometimes the family members would request that, in keeping with explicitly stated wishes of the patient. And we would have them sign a document that is consistent with the hospital, you know, uh, policies, and we would withhold resuscitative measures if that's deemed to be in the best interest of the patient.
So if a patient is completely unable to communicate their wishes, is it the responsibility of the family or people that are close to the person?
It doesn't. So if the patient has no ability to convey, we would see, we'd sit with the patient's family representatives, next of kin, to see if they've ever had a chance to speak on the matter, have a conversation on the matter. And if that was ever the case, um, where any of the patient's wishes or views on the matter made explicitly known. Now, if the family members are clear on that, my dad would never want this to be done. He would never want to go on life support, or my mom or my sister, um, if they lose their ability to say taste food, eat by mouth, they would never want their life to be prolonged. So we've had these instances where they were very, very clear. Um, Now, the problem is not in these circumstances. The problem always happens when there is a conflict within the family, when there is a difference of opinion within the family. And in that case, we would always refer to one medical principle, which is non-maleficence, or in Latin, primum non nocere, which is first do no harm. Um, so there are different guiding principles when it comes to medical ethics. One is patient autonomy. Second is paternalism. Paternalism is, what do you believe is best for the patient, right for the patient? Now, patient autonomy always trumps paternalism, because the patient is an individual, not someone that you control and, you tell them what to do. So between autonomy and paternalism, patient autonomy trumps. Similarly, patient autonomy trumps even the physician's sense of non-maleficence. So, if the patient feels that, extubate me, and there are patients who could convey that, when they've been on ventilator long enough, they've not been able to enjoy a good quality of life, they will say, just take me off life support. And they can convey this either through writing, so when they are intubated, they lack the ability to speak, or they may have indicated in writing through an advanced medical directive or through a healthcare proxy or a healthcare power of attorney. So if these things are explicitly made known, we would go with that. Otherwise, we refer to other ethical principles that guide us, and there are a few of them. And we would see in the pecking order which one would be the most appropriate and applicable to the given situation.
So about the part of when the patient is incapacitated and discussing with the family or next of kin, what if the people that, how can you know for sure that the people you're interviewing are being completely truthful and they're not just trying to benefit out of something?
Yeah. So whenever there is a question of either a conflict of interest or a conflict of opinion within the family, we would refer to professionals in the hospital, who would assist with us. Who are these professionals? They're a part of the risk management team, and there is usually a lawyer present, and they help tease out these issues when it is more than uh, anything more complicated than something that's obvious. Yeah. In most situations, it is fairly straightforward and obvious. Um, Between patient autonomy and best medical practices, we are able to resolve that. But when there is a total absence of direction from the patient, and then there is a conflict, or when they want us to do something that's not medically beneficial, we would get a risk management department of the hospital involved.
Okay.
And
So
if there are ethical principles like different conflicting, so there is also an ethics committee in most hospitals that we can refer the matter to. And they don't go into legal issues, but they tell you what is morally the right thing to do. And between different if there's a conflict between beneficence and non-maleficence, for example, beneficence is doing good for the patient, and non-maleficence is not doing harm. And there are many situations when there is a conflict between these, or between patient autonomy, or there are inconsistent wishes expressed at different points of time, and that we have a moral conflict. We get an ethics consult, uh, which is available. Yeah.
So how do so if the let's say the patient is completely able to communicate their wishes, how do doctors make sure that the patient who's asking for help is making this decision freely and isn't being pressured by any external sources, for example, their family or like other people?
Yeah. I can tell you that we usually don't make this decision on the first day that we encounter the patient unless there is a legal document saying that this is what I want you to do. I have done this, this was witnessed by so and so, my lawyer, and everything, and this, yes, and this is on the file. So if we have a clear guidelines, we follow that. But short of that, this is usually a patient we know over months, if at least weeks, if not months or years. So I'll give you an example. So this is, say, someone comes to you with a cancer. The oncologist would have managed the patient to stages 3 and 4 and tried different things. They would have interacted with multiple members of the family over time. They would have been present not only at the patient's bedside, but at the outpatient clinic visit. And you get a feel for the family, you get a feel for the patient. And who brings the patient to to the visit, to the doctor's visit for chemotherapy, who is by the patient when chemotherapy is being administered. So you would, on most instances, I would say even up to 95%. I mean, where we deal with a patient who's a total stranger with no prior knowledge, that's extremely uncommon. And in these situations, we will not rush to make a decision, especially when there is conflict between ethical principles, conflict between members of the family, conflict between, whatever. We would not make the decision in a rush. That I can assure.
So what if someone who is very sick is going through also like an internal mental battle? Are they offered like, but they're unable to like walk or something? Are they offered any like therapy, or do people try to like help them out of that headspace, or do they just go by their wishes when they're not completely like in a good
Yeah, I can tell you that 90 out of 100 patients, when they're extremely sick, it not just affects the physical dimension. You probably remember how was the last time that you felt sick? Probably not great. Food did not taste well. You didn't have the energy. You probably, if you were quarantined, you couldn't meet your friends or family. Uh, Probably you have some physical discomfort. So there will always be an acceptable amount of, uh, can I say, psychological impact of their physical conditions. Now, when that is more than what is uh, considered the norm or typical, um, we do have professionals in the hospital setting and in the outpatient setting, be it a psychiatrist or be it just some hospitals, they can get you know like chaplains, like religious chaplains, and so all kinds of then we have social workers. Many of the social workers have a psychological background. They background in psychology, that's what I meant. um, and we have access to counseling, and so the current modern health system is very well resourced to handle, because as patients become older and more medically complex, as medical advances are keeping our patients alive for a longer period of time, but also uh, able to live with advanced illnesses. There are patients who have stage 4 cancer these days, and they can go on for years, right? So the healthcare system has also been adequately sort of resourced um, to meet these needs of the patients. Yeah.
So you mentioned age just now, and I want to ask you, are there differences in the treatment of people in such circumstances throughout their ages? Like, for example, if like a 20-year-old person versus like a 90-year-old person?
Um, so where the age is really hard, black and white, is the legal age for consent, right? So a child is we go with what the parents say, and the parents would obviously know the child the best, more than sometimes us doctors. We know the medical conditions better, but as a person, I think so. There are legal provisions for parents to basically consent on the behalf, not legal provisions, but that's the norm, unless a child is an emancipated child, which can happen in very, very rare circumstances. So yeah, so there is a clear age cut. Now, not all 90-year-old are the same, not all 20-year-olds are the same, right? So for all other instances, somebody who has so the 20-year-old is an interesting thing. For many things, you are an adult, but in Singapore, the age of consent is 21, right? So uh, for example, and that's true for every society. In the US, for example, you could probably enlist in the army when you're 18, but to buy beer, you need to be 21 or above, right? So every society, they have different rules and values and whatnot. But yes, so there would be a difference, 20 and 90. But I would say that anybody at any age is a unique individual. We can't assume all of them to have an equal understanding of their illness, equally resourced to manage their medical problems, similar values just because they belong to a particular age group. So everyone is in that sense very unique, and we have to understand that unique person and their unique medical situation and their psychosocial support system, values, and everything. Everybody is unique. Yeah.
So the laws in Singapore relating to this topic, I think you talked about it like early in the interview. They don't have euthanasia, right?
That's true.
But do they have assisted dying? And can you expand on that?
No, they don't have assistance. So physicians cannot recommend a way for the patient to end their lives. So that is the basic principle of physician assisted suicide. Then there is but it's available in, I'm saying again, it's available in most states in Australia. And I know of the system from talking to my friends who practice there, but I'm no first-hand expert on the matter, right? But what I know from talking to my friends is that the physicians can, there is a committee that sees if physician-assisted dying is appropriate for the situation. There are two conditions that need to be met. One, the patient should be terminally ill. Two, they should have the ability to consent. They must be compos mentis. They should have and as a part of being compos mentis, they should not be clinically depressed. So depression, you can come out of depression, and then, so these two things are absolutely non-negotiable. And once the social worker, the psychologist, the doctor have seen them, then there is a cocktail like pentobarbital or one of those medicines that put you in a deep sleep, and then that can stop your life, right? Uh, so this is available like I said, it's available in Australia, but they're also available in Switzerland, where the doctors can also administer if the patient is incapacitated. Let's say somebody is quadriplegic, they lack the motor ability to just push the syringe. So both euthanasia and physician-assisted dying is available in certain countries, but not in Singapore. Yeah.
So, do you have any advice to give to family, especially kids, when their loved one is facing a decision like this? And how do you help them understand the process and their feelings?
Yeah. So first is the patient has a right to have an opinion on what they needs to be, what they want to be done to them, how they want to be looked after. They have a set of values. So sometimes we bounce things off family as a sounding board, but they are not trying to make the decision on the behalf of the patient, right? Let's say the patient, so I tell them that, it's not so much of a struggle that you need to do. What we want of you is to be the faithful voice of the patient. You're just a medium. If the patient is unable to communicate, you're just a medium. You're just going to be someone who's telling us or guiding us how best to look after the patient. You're not the one who's deciding. So you're not the doer in this, and you're the instrument. So that is something that can bring a lot of comfort because uh, when a family member says that, withdraw life support, it's not a decision they're making. They are just being the voice of the patient who would have wanted that to be done for them. Now, if that is not in keeping with what the patient would have wanted, we won't be doing it. It's very simple. Patient autonomy trumps everything else, right? So that's something that I tell, the patient's loved ones. I don't want you to decide for them. I want you to just convey to us what the patient would have conveyed if they had the ability to do so. Yeah.
Okay. That was my last question. I think the interview is about
All
over.
right. Good luck, Adway, and I hope you and your listeners, find it engaging. And this is a matter which, as you live life and accrue experience, you would come across many such events. And I hope that some of the words that I shared today would give you the necessary background to understand the issue better. Yeah.
Thank you.
All right. Take care. Bye
You too.
bye.
Bye.